Okay, so good morning everyone. Today we are going to talk about contrast media in radiology. This topic, to be honest, I was browsing through my e-library and I found this lecture which was presented by me when I was a first year resident in Jordan University Hospital. When I tried to update it, I found that nothing really happened during the last 5 years in the uh, topic of contrast media in general. Nothing significant, let's say, just some minor changes. So I decided to present it as it was, as I did it 15 years ago, and let's see if we can have some benefit from it. First of all, we need to know what is the role of contrast media in radiology. As the X-ray passes through the patient, they will be one of three events that will happen. Either it will be scattered, attenuated, or it will pass through the patient, depending on the thickness and the density of the particular part of the patient being imaged. So the beam will change from a uniform beam before it enters the patient into a beam that carries information after it exits from the patient, and this information will be recorded on an X-ray film or whatever, any media of recording, and then we read it and read that information. So the different tissues in the body will attenuate the beam of X-ray to a different degrees. For example, one of the major variables in how much different parts attenuate the X-ray beam is the number of electrons in the path of the beam, and this will depend on the thickness of the substance and its density and the number of electrons per atom. So there will be considerable difference, of course, in the number of atomic in the densities, depending on the atomic number of the structures in the beam of in the path of the beam. So the outline of these structures can be seen by natural contrast, not radiological contrast media. So if the tissues are of similar densities or they have the same or close average atomic number, they will not be able to be distinguished on a radiograph. So how can we see them if we cannot differentiate between them because of their close densities? So we can alter two factors. Two things can be changed in order to make them more obvious, to make these structures more obvious. First of all, is the density of organ. We can reduce it, for example, by filling a hollow organ with air, like the colon. For example, in double contrast barium enema, we push air to decrease the density of the organ. And we can also change the average atomic number by filling the organ with a liquid that has higher atomic number, which is usually iodine. An interesting information to know is that a single dose of an X-ray contrast medium contrast, that is iodine based, contains more than 2000 times the amount of iodine in the total physiological body content. So we are pushing a huge amount of iodine in order to increase the density or the atomic number of the anatomical structure. So what is contrast medium? It is any substance introduced into the body in order to make an organ or the surface of an organ or materials within the lumen of an organ visible on imaging. Okay? So anything that we push to change the appearance of the organ can be called a contrast medium. For example, you can see here in this double contrast barium enema, we can see areas of increased density here, which is due to the barium that we pushed to increase the atomic number or the average atomic number of the colon, and you can see an area of lucency here, which is due to the air that we pushed in order to decrease the atomic number of the average atomic number of the colon. So what are the uses of contrast medium? There are a lot of uses for contrast medium. The most important and the most frequent ones are including angiography, IVU, the different GI studies like barium swallow, enema, meal, follow-through, and enema. In myelography, also in CT, can we we use the contrast medium, which composes about 43% of the procedures in MRI, ultrasonography, and interventional techniques, like, for example, PTA, embolization, stenting, and of course, there are many other uses, but these are the most frequent and most commonly used ones. So, the contrast media are classified into mainly two different categories, either water insoluble like barium sulphate and water soluble. The water soluble are also classified into two different categories, ionic and non-ionic. Ionic, like, for example, Gastorgrafin, and non-ionic, or we can classify it into low osmolarity contrast medium and high osmolarity contrast medium, LOCM and HOCM. Keep in mind that the ionic contrast medium, including the Gastorgrafin, are very old. They are not used now and very infrequently used now. While most of the contrast medium that we use is also the HOCM, the high osmolar contrast media, are also very unfrequently used now. Most of the time we use the low osmolar contrast medium. So let's have some historic overview of the contrast medium. First report of a classification of the urinary tract appeared in 1923, and that was during an imaging of the abdomen in a patient with syphilis. Some kind of treatment used that back then that makes the urine more dense, and during doing an x-ray, obviously the radiologist saw some opacification of the urinary tract and concluded that it can be used as a contrast medium. So all conventional ionic water soluble contrast medium or high osmolar contrast media are hypertonic with osmolarities of more than 1200 up to 2000 milliosmol per kg of water. That's 4 to 7 times the osmolarity of the blood. And that's bad, because the higher the osmolarity of the contrast medium, the more likely it will cause side effects. So that's why we try not to use the high osmolar contrast medium, and we shift to low osmolar contrast medium. So all the attempts in the development of the different types of contrast medium are being directed toward decreasing the toxicity by decreasing their osmolarities. And now conventional contrast medium have a ratio of 3 iodine atoms per molecule to 2 particles in solutions, that is 3 to 2 or 1.5. In 1972, a new agent named dimer X appeared with a ratio of 2, that is less hyperosmolar to the blood, so it should be less. It should cause less side effects. Upon further development, two separate paths took place. First of all, is to combine 3 triiodinated benzene rings to produce an anion with 6 iodine atoms. 1 cation is necessary for each molecule, so we have 3 iodine atoms for 2 cations, for every one of these 2 cations. The second part is to produce a compound that does not ionize in solution and does not provide radiologically useless cations. We don't like the cations because they add nothing to the image, but they increase the osmolarity and might cause side effects. So the result of these 2 pathways were several non-ionic contrast medium like Omnipec, iohexol, which is Omnipec, and iopromide, that's the ultravest. For both types of contrast media, the ratio was 3 to 1. In comparison with the conventional HOCM, that's the hyperosmolar contrast medium, the new LOCM, low osmolar contrast media, show theoretical halving of osmolarity. But because of the aggregation of the molecules in solutions, the measured reduction is about 1/3. So it should be about half, but because of the aggregation in the solution, it is 1/3. So the LOCM are 1/3 less dense or less hyperosmolar than the HOCM. Okay? So now all attention shifted to the LOCM and to their use and to their development. So further development of LOCM have been the non-ionic dimers, what's called Isovest and Visipec. These have 6 iodine atoms per molecule, with the iodine concentration can now be obtained at osmolarity, and so that's good. They should be isoosmolar now. Okay, it's 1 to 1. But the problem is that these contrast medium are have high viscosity at a room temperature. They are thick, they are gel-like, so they need to be warmed up into a certain temperature and then injected into the patient. In addition, they are a little bit more expensive, so adding the warming up problem plus the expense, the higher price, they did not found a very big use in the commercial or in the everyday use of contrast media. So now we have a few, let's say, words that we need to be careful about and not to mix them up. The term low osmolar and non-ionic are not synonyms. So not every low osmolar is a non-ionic, and not every non-ionic is a low osmolar contrast medium. Only ioxalate, which is the hexabrix, is a low osmolar contrast media who's not non-ionic. Okay, it is an ionic contrast medium. يعني, I mean, hexabrix is as an ionic low osmolar contrast medium, while all the rest are non-ionic. The clinical difference between the two is that the ionic contrast media cannot be used in subarachnoid space. So you are not allowed to inject hexabrix as intradural contrast media, and you cannot make, for example, a myelogram using hexabrix. Okay? So, to summarize what's been said, all are soluble organic compounds and the contrast medium, all of them are soluble organic compounds and contains iodine, the LOCM and HOCM, I mean, the soluble ones. I'm not talking about barium, we'll talk about it later. They are either ionic monomers like HOCM, they are hypertonic or hyperosmolar. Non-ionic monomers are expensive and they need to be warmed up because they show high viscosity at room temperature. Ionic dimers have high protein binding with high viscosity, and the non-ionic dimers also have higher viscosity. And keep in mind that the low osmolar contrast media, except the isoosmolar one, the low osmolar, the LOCMs, are still hyperosmolar compared to the blood. So they are hyperosmolar, but they are less hyperosmolar than the HOCM. Okay? I mean, the HOCM has a very high osmolarity. The LOCM have a less osmolarity. However, they are still more osmolar than the blood. Okay? Keep that in mind. The everyday we use the LOCM contrast media, they are just less hyperosmolar than the hyperosmolar contrast media. This is a diagram of the chemical composition of the hyper and iso and low osmolar contrast media. I really don't care about it. It gives me headache, so I just put it for demonstration purposes. So what are the indications of low osmolar contrast media? The advantages that they provide are more comfortable arteriograms and IV injections. They are less toxic with reduction in the adverse reactions. Keep in mind, usually the intra-arterial injection of low osmolar contrast media cause less side effects than intravenous injection, and till now no one knows why. The intra-arterial injection is less dangerous than intravenous injections regarding the chemical reactions of the low osmolar contrast media. Some of them are expensive. We have some risk groups that we should pay attention when using low osmolar contrast media, including infants, children, elderly, patients with renal and or cardiac failure, poorly hydrated patients, diabetics, multiple myeloma or sickle cell anemia, previous reactions to hyperosmolar contrast media, severe allergy, and high dose procedures. I want to add some information to this slide. First of all, the only absolute contraindications to intravascular contrast media are previous reaction to contrast media. Okay, so allergy to iodinated compounds, allergy to some kinds of antibiotics like penicillin, for example, all different other things are not absolute contraindications, they are relative contraindications. Okay, the only real absolute contraindication to contrast media is previous allergy to contrast media. Okay, So if you, for example, you have patients with renal failure, he needs some sort of a CT scan with intravenous contrast medium. Is it contraindicated? No, it's not contraindicated. All you have to do is to arrange a session of dialysis after the CT scan, after the injection of the contrast medium. So you do the imaging and you shift the patient to the dialysis department, and that's it. Nothing will happen. In patients who are poorly hydrated, you just hydrate well, and then you do the imaging. All of the rest are just relative contraindications. They are not absolute contraindications. Okay. Usually, the dose that we use in contrast media is 1 to 2 cc per kg. So if the patient is like 80 kilograms weight, we can use up to 160 milliliter of contrast medium. We don't inject that the whole thing for the first time, of course. For example, if you inject 80 cc, for example, we are going at 1 cc per kg, and for some reason the cannula ruptured or the IV line ruptured and resulting in a subcutaneous injection. Does that mean the imaging is finished? It's ruined. We cannot do it again? No, it does not. Or you can inject another 80 cc by using another IV line. Okay, so you can use 1 to 2 milliliters per kg or 1 to 2 cc per kg. First, for me personally, I go with a 1 cc per kg just in case something wrong happens and I have to inject again. I have space or more safe margin of contrast injections to give. Regarding the non-water soluble contrast media, first of all, the major one that's used every day is the barium sulphate. It is a water insoluble suspension. It's used for GI examination. It has a small particle size. It is a non-ionic medium. It aggregates. It result in excellent coating, and it is inexpensive. But keep in mind, it has a higher morbidity with barium in the peritoneal cavity. So if there is any suspicion of perforation or leak of contrast into the peritoneal cavity or pleural space or any part outside the GI tract, you are not allowed to use barium sulphate. You give a low osmolar contrast medium just to be on the safe side. And when you give barium, the subsequent CT and even ultrasounds are rendered difficult to interpret because they cause high because of their very high density. The barium will cause a very big artifact on the CT scan images. So you either do the CT scan before the barium, or you wait until the barium clears up, for example 1 or 2 days before you do the CT scan. You encourage the patient to drink water to clean the barium, and before you do the CT you do an X-ray, normal X-ray, confirm that the barium has washed up completely, and then you do the CT scan imaging. What happens if there is a perforation and you used barium sulphate? There will be severe pain, hypovolemic shock, mortality up to 50%, with 30% of the patients develop adhesions and granulomas, and it will be a very terrible thing to cause as a radiologist. In cases of aspiration, the barium sulphate usually it causes some mild pneumonitis. That's nothing to be worried about, nothing to be afraid from. And when it dries up, it's so thick it will cause constipation and impaction. That's why when you use, for example, you do barium enema in an infant suspecting of having Hirschsprung disease, I prefer to use the low osmolar contrast medium because it will pull water from the colon and cause more easy defecation, while if you use barium it will hardens up and even increase the constipation and the impaction that the infant already have. However, when you use low osmolar contrast media, due to its high osmolarity, it will pull water from the body and might cause some dehydration. So keep in mind to instruct the parents to give good hydration to the infant before and after the imaging. Okay. Regarding Gastorgrafin, it's a water-soluble contrast media which contains iodine. It's a relatively old contrast medium, so it's not being used very much nowadays. The main indications is when cases of suspected perforation, meconium ileus, in cases when you want oral contrast for CT scan, It might cause some pulmonary edema because of its hyperosmolarity. It pulls water from the body into the lung and resulting in some pulmonary edema. Also might cause hypovolemia in children, as we said. It might cause allergic reactions because it contains iodine, and sometimes might cause ileus, paralytic ileus. So what are the adverse effects of the IV water soluble contrast medium? When you give IV contrast medium, what you should be aware of? First of all, LOCM have higher LD50 than HOCM by a factor of 3. So, intrinsic toxicity of contrast media is a function of osmolarity, chemical structures, and lipophilicity. So, the higher osmolarity, the different chemical structures, and the more lipophilic the contrast medium is, the more likely it will cause toxicity. There are different types of toxicities. Most of them are quite rare. However, we should be careful and we should know about them. First of all, vascular toxicity. For example, venous. There will be some pain at the site of injection along the arm or delayed pain, especially with the lower limb venography. It is 4 times more common with hyperosmolar contrast medium, the HOCM. Okay, so that's why we are preferring to use LOCM. Arterial injections might cause endothelial damage and vasodilatation, sensation of heat or pain, especially in peripheral arteriography, less with non-ionic low osmolar contrast medium. Regarding soft tissue toxicity, it will include pain, swelling, erythema, and sloughing of the skin due to the extravasated contrast medium. When the cannula is not in the vein, or when the IV line ruptures, the contrast will be injected in the subcutaneous tissues. And this is more common in CT examination because we are using automated pumps, which will continue injection even though the cannula is out, the vein is ruptured. So then we might expect this side effects of pain, swelling, erythema, and blah blah blah. Okay, but if the contrast medium is injected outside the vessel, outside the vein and the subcutaneous tissue, we don't cancel the exam. We can give more contrast by pouring another IV line and calculating the remaining safe dose that we can administer. That's why, for me personally, I prefer to use the lower limit, that's 1 cc per kg, and then just in case something happens, we can inject again. Regarding cardiovascular toxicity, a lot of things can happen like VF, VT, that's ventricular fibrillation, ventricular tachycardia, asystole, sinus bradycardia, heart block, increased QT interval, QRS prolongation, ST depression, increased T amplitude. Also, it causes increasing in the vagal activity and significant fluid and ion shift. However, that's really rare. Don't be afraid by all of these things which looks terrible and would make us not use contrast media. They are not that common, okay? And most of them will go away by themselves without intervention or need for any hospital admission or anything like that. Hematological changes will include hemolysis, hemoglobinuria, acute renal failure may supervene. It is advisable not to re-inject the blood that has been mixed with contrast medium. If you pull blood into the syringe for any reason and then don't try to inject that blood because most of the times it will be a hemolyzed blood. And if you do inject it, if it's small dose, believe me, nothing will happen from my personal experience. Contrast medium have a potentiating effect on the action of heparin, and thrombus formation can happen more with LOCM. There is a role for the syringe though. So contrast medium, if patient is taking heparin, will increase the activity of heparin, and at the same time contrast medium might cause thrombus formation if we are using some kinds of syringes that promotes coagulation. Hematological changes might include sickle cell crisis, that is less likely to happen with low osmolar contrast medium, RBC rigidity causing transient pulmonary hypertension and the transient deterioration of the renal function. Keep in mind that's transient, that's not permanent, it will go away. And the transient eosinophilia may occur 24 to 72 hours after the administration of the contrast medium. So overall, there are some side effects for the use of contrast medium. We should be careful, we should be aware from them, and we should know which one to be worried about, which one not to be worried about. and we should know what kind of contrast medium to be used in every procedure. If you have a CT scan, you don't use barium because it's very dense and will cause artifacts. If you have any suspicion of any leak in the GI tract, don't use barium. If you will need CT scan after the GI barium imaging, don't use barium, or you do the CT scan before the imaging, or wait till the barium clears for a few days before you do the CT scan, or it will be useless. Our time has finished now. We will continue maybe on the next time with the rest of the adverse effects of the contrast medium and how to manage these adverse effects. We will discuss it in details. Thank you very much. I hope to see you next time.